Hi, my name is Sharon Chen, and this video is about the lower viral respiratory tract infections. The learning objectives are to recognize the clinical characteristics of bronchitis and bronchiolitis, to describe how the clinical characteristics of bronchiolitis relate to the pathogenesis of RSV infection, to discuss potential complications, management, and prevention strategies for RSV-induced bronchiolitis, and to compare the clinical manifestations of RSV to that of human metapneumovirus. Here's the pathogen list for our course, and in this video and the entire module, I will be discussing these viruses that cause respiratory infections. We're going to use the same anatomic framework and focus on bronchitis and bronchiolitis. Influenza can cause both, but influenza is such an important respiratory virus that we will be discussing this in depth in a separate module. We already talked about laryngotracheal bronchitis in the upper viral respiratory tract infection video, so now we're going to continue down the airway to discuss bronchitis and bronchiolitis. The clinical symptoms of bronchitis really center on cough. It's a productive cough and can last for several weeks. The cough is due to attempts at clearing the secretions caused by inflammation of the mucous membranes of the bronchi. Sometimes the secretions and sputum can appear purulent, but this does not mean that the patient has a bacterial infection. The purulence is from sloughing cells mixed with mucus. In this case, because it is not a bacterial infection, you do not need to give the patient antibiotics. In fact, bronchitis is one of the leading diagnoses of inappropriate antibiotic use. Bronchitis is predominantly a viral infection, and most of the respiratory viruses that we've been discussing can cause it. Only a few bacteria can cause bronchitis. Inflammation of the bronchi can cause bronchospasm, so wheezing can be heard in these patients. However, fever and systemic symptoms are unusual, and if you see these in your patient, another diagnosis should be thought about, including influenza and pneumonia. Now we're going to discuss bronchiolitis. This is the inflammation of the bronchioles that are narrower than bronchi. Any of the viruses that we have discussed can cause bronchiolitis, but the hallmark virus is RSV. Bronchiolitis mostly affects infants and young children and has a 4 to 6 day incubation period, which is when the virus colonizes the infant asymptomatically. The upper respiratory infection symptoms and fever manifest once the innate immune system recognizes the virus and initiates production and secretion of cytokines. A third of the infants and young children with RSV infection will progress to lower respiratory tract disease, and the patient will have fast breathing or tachypnea, coughing, and respiratory distress with retractions and wheezing. Here is a video of a baby with RSV bronchiolitis. What you should have noticed is that this baby is really struggling to breathe. He's breathing fast and in respiratory distress. And you can see the pulling in of the soft tissue between his ribs and above his clavicles. This is called retractions and is caused by the baby using his accessory muscles to breathe. So how did the baby get these symptoms? The pathogenesis should be familiar to you now. It's very similar to what we discussed in detail in the upper respiratory tract video. RSV infects respiratory epithelial cells starting in the nasal mucosa and then progressing down the respiratory tract. Innate immune sensors detect PANTs and produce interferon, other cytokines, and chemokines, which then recruit the inflammatory cells. Vascular flow, permeability, and mucus production increase. The epithelial cells undergo apoptosis and slough off into the airway. All of this cellular debris and the outpouring of mucus and inflammatory cells leads to plugging up of the small airway. This can trap air and lead to poor gas exchange. With worsening respiratory distress, you should worry about potential clinical complications. Respiratory failure occurs when the patient needs to be intubated and ventilated. It does not commonly occur, but young infants are most susceptible. Apnea is also more common in newborns and premature infants. And apnea is when babies spontaneously stop breathing. This is a scary complication for both parents and doctors, especially because it occurs in very, very young babies. Now, there are certain patient populations, such as newborns and the elderly, who are at risk of more severe disease, either because they have pre-existing lung problems or a relatively deficient immune system. You should keep these populations in mind because it may affect your decisions about how you manage and treat your patient. Here are several things you should think about when you manage and treat a patient with bronchiolitis. So first, you want to figure out how much respiratory distress your patient is showing. What is her oxygenation? Does she have retractions? Is she eating and drinking normally, or is she having such a hard time breathing that she can't eat or drink? In addition, you want to know if the patient is actually getting worse or getting better. Next, you want to know if your patient is in a high-risk group for having severe disease. I already mentioned these patient populations in the previous slide. If you find that your patient is having a really difficult time breathing and or is in one of these high-risk groups, you may want to admit her for closer monitoring. Now, treatment of bronchiolitis is predominantly supportive. You should supplement oxygen and monitor for apnea. In some situations, you may need to intubate and mechanically support the infant's breathing. Nasogastric feeding or intravenous fluids is important to think about. Remember, this baby might be quite dehydrated because she hasn't been able to take her bottle. Because bronchiolitis symptoms can be analogous to asthma, some drugs that are used in asthma to overcome airway obstruction have been tried for bronchiolitis. These include bronchodilators, epinephrine, corticosteroids. However, the results have been disappointing. Although many respiratory viruses can cause bronchiolitis, RSV is the prototypical virus. Because it causes mostly bronchiolitis, RSV is the most important viral pathogen during the first year of life. Unlike many of the other respiratory viruses, RSV has only one serotype. So it's a bit surprising that reinfections are common with RSV. Now, RSV is in the Paramyxoviridae family, just like parainfluenza virus and Metapneumovirus, both of which can also cause bronchiolitis. Paramyxoviridae family are all RNA envelope viruses. RSV has two important proteins. You can see them sticking out of the capsid in the cartoon drawing. Both of these proteins are important in eliciting neutralizing antibody. The G protein is for attaching the virus to the host cell receptor, although the actual receptor is not known. The F protein is important for fusing the viral envelope to the membrane of the respiratory epithelial cell. In cell culture, the F protein fuses cells together, forming a syncytium. This is where RSV got its name, respiratory syncytial virus. Syncytium formation is a cell culture phenomenon. How is it with one serotype can RSV cause reinfections? Well, RSV has multiple mechanisms of evading the immune system. The development of neutralizing antibody is made at a low frequency, and this may be because the G protein is heavily glycosylated and interferes with antibody production. It can also be made in a secreted form, acting as a decoy for neutralizing antibodies. RSV can also affect T cells by infecting dendritic cells, which then decreases their ability to present antigen to T cells. Cytotoxic T cells that recognize RSV in the lung don't secrete key cytokines like IL-2 and interferon gamma. These are important for killing the infected cell. These examples of evading and modulating the host immune response may explain why natural immunity is not complete and not sustained. The important point to remember here is that protective immunity against RSV is incomplete and short-lived. The examples I have given you are only to illustrate this point. One other important point. The host immune response may not be robust, but it's also not zero. RSV reinfections tend to not be as severe, suggesting that the immune response was protective enough against severe disease, but not infection. Viral disease is from actions of the virus and from the host. The clinical pattern that we observe on the host side is that most children older than 2 years of age don't get severe RSV disease. Why is that? We already said that infants and young children have smaller airways, which increases their risk of severity. An added disadvantage is that infants are born with an immature immune system, and this is in addition to the mechanisms that RSV uses to evade and modulate the immune response. I just discussed how an immature immune system can lead to disease. An overexuberant immune response can also cause disease. Wheezing is a clinical symptom common to RSV bronchiolitis and asthma. There is a group of children who continue to have recurrent wheezing even without getting RSV infection. Some of these children will eventually be diagnosed with asthma. Now, it's unclear whether RSV bronchiolitis causes asthma or is indicative of a child prone to asthma. There is no RSV vaccine available. Physicians do have other means of providing some protection to infants. This is in the form of passive immunity, and the monoclonal antibody is called palivizumab. This is an antibody against the F protein. It is given as an intravenous infusion and given to high-risk groups of infants and young children less than 2 years of age. The most recently discovered virus in the Paramyxoviridae family is human metapneumovirus. It was discovered in patients who clinically had bronchiolitis, very similar to RSV bronchiolitis, but RSV could not be isolated. Human metapneumovirus essentially mimics RSV. Both are in the same virus family and thus are enveloped RNA viruses. Human metapneumovirus also has only one serotype. You should recognize the cartoon image of the virus because it's very similar to RSV. Human metapneumovirus also has a F and G protein. The epidemiology and clinical disease for human metapneumovirus and RSV are the same. This slide is all of the lower respiratory tract virus infections for you to review later.